Hi, welcome back to your prescription for medication education. My name is Enmi, and I'm a pharmacist. And if you'd like to learn about medications, then this is the right channel for you. Today I'll be going over loop diuretics. I like to start off my videos with 5 questions. These questions are based off of the information that I provide during the video. So question number 1, a patient receives 40 milliequivalents of potassium chloride. Using the general estimate provided, the expected serum potassium increase is approximately A, 0.1 milliequivalents per liter, B, 0.2 milliequivalents per liter, C, 0.4 milliequivalents per liter, or D, 1 milliequivalent per liter, or E, 2 milliequivalents per liter. Question number 2, a patient with anuria is prescribed furosemide. Why are loop diuretics generally contraindicated in this setting? A, they require active renal tubular secretion and urine flow to reach the tubular lumen. B, they require glomerular filtration as their only route of delivery. C, they directly worsen hyperkalemia by blocking renal outermedullary potassium channels. D, they increase calcium reabsorption and cause hypercalcemia. Or E, they are ineffective because sodium-potassium chloride cotransporter 2 is located in the collecting duct. Question number 3, a patient has a serum potassium of 3.1 milliequivalents per liter, no ECG changes, no severe symptoms, and a functioning GI tract. Which replacement approach is generally preferred? A, IV potassium chloride only, B, oral potassium chloride, C, dietary potassium alone, D, sodium bicarbonate infusion, E, magnesium sulfate only. Question number 4, a patient taking digoxin is started on high-dose furosemide and later develops hypokalemia. Why does hypokalemia increase digoxin toxicity risk? A, low potassium reduces digoxin binding to sodium-potassium ATPase. B, low potassium increases digoxin binding to sodium-potassium ATPase. C, low potassium increases renal clearance of digoxin. D, low potassium blocks digoxin absorption. Or E, low potassium prevents digoxin from entering cardiomyocytes. Okay, and the last question, question number 5. Which statement best explains why hypoalbuminemia may reduce loop diuretic delivery to the kidney? A, less albumin binding increases glomerular filtration of the drug. B, less albumin binding reduces proximal tubular secretion into the lumen. C, less albumin binding prevents hepatic metabolism. D, less albumin binding increases sodium-potassium chloride cotransporter 2 expression. Or E, less albumin binding increases distal sodium reabsorption. Let's do a quick and simplified refresher on sodium reabsorption across the nephron. The proximal tubule reabsorbs about 65% of filtered sodium through the sodium-hydrogen exchanger. The thick ascending limb of Henle reabsorbs about 25% via sodium-potassium 2-chloride cotransporter. The early segment of the distal convoluted tubule reabsorbs about 5% through the sodium chloride cotransporter. And finally, the late distal convoluted tubule and collecting duct reabsorbed only about 2 to 3% of filtered sodium via the epithelial sodium channel. Loop diuretics work by inhibiting the sodium-potassium 2-chloride cotransporter located on the apical membrane cells in the thick ascending limb of the loop of Henle. This results in the reabsorption of up to 25% of filtered sodium and chloride, so this results in natriuresis and diuresis. Loop diuretics are highly bound to albumin, which limits them from being filtered by the glomerulus. The way loop diuretics enter the tubular lumen is through active tubular secretion via the proximal tubules. Organic anion transporter 1 and 3, located on the basolateral membrane of the proximal tubule, facilitate the movement of loop diuretics from the blood into the proximal tubular epithelial cells. Once inside the cells, the drug is secreted into the tubular lumen. Once inside the tubular lumen, loop diuretics travel to the thick ascending limb and bind to the chloride binding site of the NKCC2 transporter, which prevents the reabsorption of sodium, potassium, and chloride. Furosemide was approved in the 1960s and is available in various formulations, including an oral tablet, oral solution, as well as an injectable formulation for IV infusions, and it's also available in a prefilled cartridge, which is used with a drug device for subcutaneous infusions. Although oral furosemide may be used for hypertension, it is not a first-line antihypertensive and is mostly used in patients who are volume overloaded. For edema, Its initial oral dose is 20 to 40 milligrams once a day and is titrated based on the patient's response. If further diuresis is needed, its doubling the dose is often more effective than increasing the frequency. It's important to protect furosemide from light to prevent it from degradation. For patients with an eGFR of less than 30 or patients with impaired hepatic functions, its diuretic response may be decreased. Its drug interactions include digoxin, photosensitizing medications, NSAIDs, and sucralfate. Bumetanide was approved in the 1980s and has two brand name formulations available, Bumix and Enbumyst. It's available in tablets, vials, and a single-use nasal spray. It's indicated for the treatment of edema and does not have a labeled indication for hypertension. Compared with furosemide, it has more reliable oral absorption, and the labeling states that the oral and parenteral administration produce almost equal diuretic responses. This allows for easy conversion between oral and IV dosing. For edema, the usual starting dose is 0.5 to 1 milligram once a day orally or IV. The dose is titrated based on response with a recommended maximum dose of 10 milligrams per day. Torsemide was approved in the 1990s and is only available in an oral tablet formulation. Unlike furosemide, its labeling does have an indication for the use in hypertension. The dosage range provided for hypertension is much lower than indicated for the treatment of edema. Its initial starting dose is 5 milligrams with a recommendation to titrate to 10 milligrams if needed in about 4 to 6 weeks. For the treatment of edema, it has a maximum recommended total daily dose of 200 milligrams. Unlike furosemide and bumetanide, torsemide has a longer duration of action which allows it to be dosed once a day. As an interesting side note, torsemide has a once-a-day extended-release formulation called SOANS. Sarfez Pharmaceuticals, the manufacturer, was issued a warning letter from the FDA Office of Prescription Drug Promotion because promotional materials allegedly made false or misleading claims about the drug's efficacy and risks. Loop diuretics lower blood pressure modestly. A Cochrane systematic review of 9 randomized control trials found that loop diuretics lower systolic blood pressure by about 8 millimeters of mercury and 4 millimeters for diastolic readings compared to placebo. However, the evidence was graded as low quality. Furosemide and bumetanide have a short duration of action of about 4 to 6 hours when dosed once daily, meaning their natriuretic effect may wear off before the next dose. During this period, post-diuretic sodium retention can occur. This is where the kidneys intensely reabsorb sodium and water following the initial sodium loss induced by a diuretic, which often leads to a diuretic resistance, which can lead to less sustained blood pressure reductions. This contrasts with thiazide diuretics that produce a more sustained natriuresis with proven cardiovascular benefits in large trials. Loop diuretics still have an important role, but they are generally reserved for specific clinical scenarios, such as hypertension with clinically significant volume overload, heart failure, or advanced CKD. For patients with advanced CKD, which is commonly defined as an eGFR of less than 30, loop diuretics are often still effective for volume management, unlike some thiazides, which lose their diuretic efficacy below this range. However, we have to keep in mind that there are no cardiovascular outcome data supporting loop diuretics for the treatment of hypertension with or without CKD, which is one of the primary reasons they are not recommended as first-line agents. Loops are generally contraindicated in patients with anuria, commonly defined as a urine output of less than 100 milliliters per 24 hours. In an anuric patient, loops are usually ineffective and are likely to cause harm. If you remember from earlier, loops must be secreted into the tubular lumen to reach their site of action in the thick ascending limb. With little to no urine flow occurring, this means the drug cannot be delivered to its site of action in the tubular lumen. Furosemide is mostly renally cleared, and in anuria, furosemide's half-life is significantly prolonged, leading to systemic drug accumulation and toxicity. Ototoxicity is one of the most clinically significant risks. Loop diuretics can block ion transporters in the stria vascularis within the inner ear. When loop diuretics inhibit sodium-potassium chloride cotransporters in this area, potassium handling becomes disrupted. This can rapidly reduce the endocochlear potential, which is the electrical gradient that allows hair cells to detect sound, which can result in outer hair cells to lose their ability to amplify sounds, leading to hearing changes, tinnitus, and hearing loss. Loop diuretic ototoxicity is usually reversible, but irreversible hearing loss can occur. Among the sulfonamide-based loop diuretics, furosemide carries the greatest ototoxic risk in the setting of renal failure. Bumetanide and torsemide are predominantly hepatically metabolized, so their half-lives are better preserved in renal dysfunction, resulting in less systemic accumulation. For patients receiving high-dose or prolonged loop diuretic therapy, hearing loss pre-treatment audiometry and weekly testing is advised, especially in the setting of renal impairments. Loop diuretics produce clinically significant electrolyte imbalances. Hypokalemia is one of the most common electrolyte imbalances and one of the most dangerous in terms of arrhythmogenic potential. This occurs because more sodium reaches the collecting duct, where sodium is reabsorbed, affecting the electrochemical gradient for potassium secretion via renal outer medullary potassium channels. The degree of hypokalemia that occurs is influenced by dietary sodium and higher doses, and especially if a patient is on a thiazide diuretic. At the cellular level, hypokalemia can hyperpolarize cardiac cells and delay repolarization, which increases the risk for arrhythmias. ECG findings may include ST depression, T-wave flattening, prominent U waves, and QT prolongation. Loop diuretics can also cause hypomagnesemia. About 60 to 70% of filtered magnesium is reabsorbed in the thick ascending limb. Inhibition of NKCC2 transporters reduces the lumen positive voltage that normally drives paracellular magnesium reabsorption. This matters clinically because hypomagnesemia can make hypokalemia difficult to correct until magnesium is also repleted. Hypochloremic metabolic alkalosis is a classical hallmark acid-base disturbance of loop diuretic therapy. Loop diuretics increase chloride excretion significantly, with some sources stating as much as 20 times. It occurs through chloride loss, volume contraction, increased bicarbonate retention, secondary hypoaldosteronism, and hypokalemia. This alkalosis is classified as chloride responsive, meaning the patient is depleted of chloride and volume. Once the diuretic wears off, a low urine chloride, such as less than 10 milliequivalents per liter, suggests the kidneys are trying to conserve chloride. Treatment requires chloride repletion, which typically responds to isotonic saline and potassium chloride. Hypocalcemia and hypercalciuria also occur. This is the opposite of thiazides, which typically promote calcium retention. In neonates, furosemide-induced hypercalciuria increases the risk for nephrocalcinosis. One study found that cumulative exposure above 10 milligrams per kilogram was associated with an approximately 48-fold increased risk. Lastly, hyponatremia can occur, but is less common than with thiazides. Loops reduce the kidney's ability to concentrate urine, which causes proportionally more water to be excreted than thiazides. The American Academy of Family Physicians published a useful review titled Potassium Disorders, Hypokalemia and Hyperkalemia in January 2023. Some of the following information is based off of that review. A normal serum potassium is defined as 3.5 to 5 milliequivalents per liter. Patients with severe signs and symptoms such as arrhythmias, paralysis, respiratory failure, or weakness should be treated with 5 to 10 milliequivalents of IV potassium chloride over 15 to 30 minutes and placed on cardiac monitoring. IV potassium should be given in glucose-free fluids to avoid intracellular potassium shifting due to insulin release. Treatment can be repeated until the patient is stable with resolution of ECG changes and serum potassium is greater than 3 milliequivalents per liter. Once stable, additional IV isotonic solutions containing 20 to 40 milliequivalents per liter can be given peripherally with infusion rates up to 10 milliequivalents per hour. Rates higher than this require cardiac monitoring and the use of a central line. For patients with a serum potassium of 2.5 milliequivalents per liter or higher, no severe symptoms, and a functioning GI tract, oral potassium chloride is preferred over IV because of lower risk of rebound hyperkalemia than IV replacement. Potassium chloride is the preferred formulation because it is the most effective for raising serum potassium. As a general estimate, 10 milliequivalents of potassium may raise serum potassium by about 0.1 milliequivalents per liter. Increasing dietary potassium alone is inadequate for diuretic-induced hypokalemia because most potassium in foods is coupled with phosphate rather than chloride, and is therefore not effective in replacing potassium losses associated with chloride depletion. A typical maintenance dose during ongoing diuretic therapy is between 40 to 100 millimoles per day. In the US, potassium products are usually listed in milliequivalents. Because potassium is monovalent, 40 to 100 millimoles per day equals 40 to 100 milliequivalents per day. When choosing oral formulations, liquid or effervescent preparations are preferred because tablets carry a small risk for GI ulceration. Potassium-sparing diuretics are more effective than oral potassium supplements at correcting and preventing diuretic-induced hypokalemia. The 2025 AHA-ACC guidelines recommend rechecking kidney function and serum electrolytes 2 to 4 weeks after starting or increasing diuretic doses. Loop diuretics are associated with photosensitivity reactions. Phototoxicity is dose-dependent and light-dependent. The drug or its metabolite absorbs ultraviolet radiation, mostly UVA, and the absorbed energy drives photochemical reactions which directly damage cellular components. Furosemide contains a chlorine substituent in its chemical structure which can undergo UV-related photochemical degradation, which can generate free radicals that react with lipids, proteins, and DNA in the skin, producing an exaggerated sunburn-like reaction. A recent randomized control pilot study published in the European Journal of Pharmaceutical Sciences confirmed that furosemide was among the drugs associated with the highest increase in erythema in response to both UVA and UVB irradiation. For counseling, patients should be recommended to use broad-spectrum sunscreen with SPF 30 or higher that also meets UVA protection criteria. Standard SPF ratings measure only UVB protection. A sunscreen with a high SPF but poor UVA coverage would leave a patient on furosemide essentially unprotected against the relevant wavelengths. I reviewed sulfa allergies in my diazides videos, so in this video I'll briefly just mention that clinically significant cross-reactivity between sulfonamide antibiotics and non-antibiotic sulfonamides is unlikely. However, in the case of a patient with a documented severe or life-threatening reaction to sulfonamide-containing drugs, then ethacrynic acid is the only loop diuretic that does not contain a sulfonamide moiety. Ethacrynic acid carries its own significant limitations though, notably the highest ototoxic risk among the loop diuretics, and its limited availability along with being quite expensive the last time I checked. Loop diuretics can also cause hypersensitivity reactions independent of sulfonamide allergies. Reported reactions include rashes, urticaria, rare anaphylaxis, severe cutaneous adverse reactions, and rare organ-specific immune injury such as acute interstitial nephritis. Digoxin and loop diuretics have a clinically important interaction because loop-induced hypokalemia and hypomagnesemia can increase the risk of digoxin toxicity. Digoxin exerts all of its therapeutic and toxic effects by inhibiting the sodium-potassium ATPase pump, which normally moves sodium out and potassium into cardiomyocytes. Potassium and digoxin compete for the same binding site. So when extracellular potassium falls due to loop diuretics, the ability of potassium to compete with digoxin for this binding site is reduced, resulting in greater digoxin binding and more profound pump inhibition at any given serum digoxin concentration. This means that digoxin toxicity can occur at serum levels that would otherwise be considered therapeutic. The ACC/AHA guidelines note that toxicity may occur at levels below 2 nanograms per milliliter when hypokalemia, hypomagnesemia, or hypothyroidism coexist. Loop diuretics cause concurrent hypomagnesemia, which independently predisposes to digoxin toxicity. Hypomagnesemia itself promotes triggered activity and delayed after depolarizations, lowering the threshold for digoxin-induced arrhythmias. The ACC/AHA heart failure guidelines and the FDA digoxin label recommend the following for patients on concurrent digoxin and loop diuretics, which is to maintain potassium in the normal to high normal range. So we want to target a serum potassium of greater than 4 milliequivalents per liter. In heart failure, target serum digoxin levels between 0.5 to 0.9 nanograms per milliliters, as higher levels are associated with increased mortality, without additional benefit. As a reference, traditional ranges for digoxin are between 0.8 and 2 nanograms per milliliters. The answers to the questions at the beginning of the video are 1 Charlie, 2 Alpha, 3 Beta, 4 Beta, 5 Beta. And that was your dose for medication education. I do hope you enjoyed today's video and you learned a lot. If you did, please consider subscribing and sharing my channel. Also, feel free to leave me some feedback, anything, what you like, what you don't like. Anyways, thank you. Have a great day.